Krishna. Hi Ashok. Good morning. Yep.
Let's start by reviewing the major chambers of the heart. Blood enters the right atrium of the heart via one of two structures. The first is the superior vena cava, which drains blood from above the heart. The other is the inferior vena cava, which drains blood from below the heart. From the right atrium, blood moves into the right ventricle, and from the right ventricle, it is pumped out via the pulmonary artery and into the lungs. After blood moves through the lungs, it enters the left atrium of the heart via one of four pulmonary veins. You find the entrance to the pulmonary veins in the left atrium. From the left atrium, blood moves into the left ventricle, and from there it is pumped into the aorta. Notice also in this picture that the walls of the left ventricle are drawn and they are thicker than the walls of the right ventricle. That is the same thing you see in the anatomy lab. The reason the walls of the left ventricle are thicker than the right ventricle is because the left ventricle has to generate much higher pressures in order to pump blood to the entire body. The right ventricle does not need to generate such high pressures, therefore it has thinner walls and less muscle. There are four valves found in the heart. The tricuspid valve is located between the right atrium and the right ventricle. The pulmonic valve is located between the right ventricle and the pulmonary artery. The mitral valve is found between the left atrium and the left ventricle. And finally, the aortic valve is found between the left ventricle and the aorta. All of these valves have three subscrotal leaflets except for the mitral valve, which has two leaflets. We'll talk more about that in a minute. Shown on the screen is a cardiac MRI image from a patient of mine, and I've shown you this to demonstrate the anterior-posterior relationship of structures inside the chest, including the heart and great vessels. So to help orient you, this is a cross-section through the chest, and the black areas on the sides are the lungs, and in the middle of the picture is the heart and the aorta. Contrast material has been injected into the vascular system so that blood appears white. So in the front of the chest, we have a structure that is holding blood, and that is the right ventricle. Notice that it's an anterior structure. The right ventricle is anterior to other parts of the heart, and therefore it's often injured in penetrative trauma that goes through the chest wall, though other structures can also be damaged as well. Behind the right ventricle, there's another structure holding blood, and that is the left ventricle. Notice that the left ventricle is surrounded by these walls, which are relatively thick. Notice also that the right ventricle has walls that are thinner, just like we talked about in the last picture. This structure in the back of the chest that I'm circling with my pen is the left atrium. Notice that the left atrium sits right on top of this black hole here. That black hole is the esophagus, and it sits just behind the left atrium. Behind the esophagus, you find another circular structure that contains blood, and that is the aorta. So it's helpful to remember that the esophagus sits between the left atrium and the aorta. This will help you understand By cardiologists like we sometimes take pictures of the heart by inserting a probe in the esophagus. That test is called a transesophageal echocardiogram. The reason we do this is because the esophagus is right next to the left atrium and the aorta. It's also very close to the mitral valve right here, so we can get very close-up pictures of these structures if we place an ultrasound probe in the esophagus. You should also be aware that if the left atrium becomes massively dilated, it can potentially compress the esophagus and cause dysphagia. This is rare, but it sometimes occurs in cases of severe mitral stenosis. I'd like you to understand for your boards what can be the atrium becomes if we place an ultrasound probe in the esophagus. You should also be aware that if the left atrium becomes massively dilated, it can potentially compress the esophagus and cause dysphagia. This is rare, but it sometimes occurs in cases of severe mitral stenosis. I'd like you to understand for your boards what can be affected if the left atrium becomes massively dilated. And now that you've seen this picture, hopefully this will help you remember that the esophagus is right next to the left atrium. Let's talk about the coronary arteries. If you look at the picture on the screen, this red structure here that I'm drawing a line through with my pen is the aorta. Coming off of the aorta are two vessels that supply blood to the heart. The first one is called the left main coronary artery. It bifurcates into two vessels, the LAD, the left anterior descending coronary artery, and the left circumflex coronary artery. The LAD artery supplies the blood to the anterior wall of the left ventricle. The left circumflex supplies blood to the lateral wall of the left ventricle. Also coming off of the aorta is the right coronary artery. It supplies blood to the right ventricle and then wraps around the side of the heart and goes underneath. The posterior descending artery is not shown in this picture, but it supplies blood to the inferior wall of the left ventricle. In about 90% of people, the PDA is a branch of the right coronary artery. We call those people right dominant. In 10% of people, the PDA supplies blood to the inferior wall of the left ventricle. In about 90% of people, the PDA is a branch of the right coronary artery. We call those people right dominant. In 10% of people, the PDA is a branch of the left circumflex. We call those people left dominant. Venous blood that drains away from the myocardium goes into a structure called the coronary sinus, not shown on this picture. The coronary sinus drains into the right atrium just like lots of other venous blood, and you're sometimes asked in board exams, what could cause a dilated or enlarged coronary sinus? And the answer is anything that raises the pressure in the right atrium, because the coronary sinus drains blood into the right atrium. If the pressure is high in the right atrium, the coronary sinus can become enlarged. When you hear people talking about myocardial infarctions, they'll often say that a patient had an anterior wall myocardial infarction or an inferior wall or a lateral wall myocardial infarction. And what they're referring to when they use those terms are the walls of the left ventricle. When people have heart attacks, we want to know which walls of the left ventricle are involved, and it's important for you as a medical student to understand which blood vessels supply which walls of the left ventricle. So let's talk about that now. These are the coronary artery territories supplied by each vessel. So the anterior wall, the anterior septum between the ventricles, and the apex of the left ventricle is all supplied by the left anterior descending artery. This is easy to remember because the artery has the word anterior in its name. The lateral wall of the left ventricle is supplied by the left circumflex. I used to remember this by just thinking of the vessel as the lateral circumflex instead of the left circumflex. Use that if you wish. And then finally, the inferior wall and the inferior septum between the left and right ventricle are supplied by the PDA. As I told you on the last slide, 90% of patients, the PDA goes off the right coronary artery. The other 10% of people are called left dominant. In these patients, the left circumflex supplies the PDA. And in terms of myocardial infarctions, the LAD is the artery that is most commonly infarcted. The circumflex is the least likely to be infarcted, and the RCA is in the middle. And I talk about all this in more detail in the modules on ischemia. Let's talk about the mitral valve. The mitral valve has two leaflets, an anterior leaflet and a posterior leaflet. And the leaflets are tethered to two papillary muscles by structures called chordae tympani, which I'm circling in this picture. The two papillary muscles are the anterior lateral papillary muscle and the posterior medial papillary muscle. Some people just call them the anterior and the posterior papillary muscles. One thing that's high yield for you to know about these two papillary muscles is that the anterior lateral papillary muscle usually has a dual blood supply from both the LAD and the circumflex. This makes it relatively resistant to ischemia because, for example, if you had an infarction in the left circumflex artery, the anterior lateral papillary muscle would still get blood from the LAD. The posterior medial papillary muscle, on the other hand, often has a single blood supply, usually from the right coronary artery or sometimes from the circumflex. What this means is that the posterior medial papillary muscle is more vulnerable to ischemia and and can potentially rupture in the setting of a myocardial infarction. In the ischemia module, posterior medial papillary muscle, on the other hand, often has a single blood supply, usually from the right coronary artery or sometimes from the circumflex. What this means is that the posterior medial papillary muscle is more vulnerable to ischemia and can potentially rupture in the setting of a myocardial infarction. In the ischemia modules, I talk about the fact that one of the dangerous consequences of myocardial infarction is for a papillary muscle to rupture. The patient will develop severe mitral regurgitation and acute heart failure. This is often a fatal event. The papillary muscle that often ruptures is the posterior medial papillary muscle. This often occurs in the setting of an inferior wall myocardial infarction. And the reason it's the posterior medial papillary muscle that usually ruptures is because it has a single blood supply in most cases. I'll finish by reviewing the anatomy of the cardiac electrical system. So electrical activity through the heart is generated under normal circumstances by the SA node, which is found on the lateral wall of the right atrium. From the SA node, electrical activity goes through both atria, but it can only reach the ventricle by going through the AV node. The AV node is found on the interatrial septum. This is the wall between the left and right atria. From the AV node, electrical activity travels through the His bundle and then the right bundle branch the ventricle by going through the AV node. The AV node is found on the interatrial septum. This is the wall between the left and right atria. From the AV node, electrical activity travels through the His bundle and then the right bundle branch and the left bundle branch, and finally it travels to the Purkinje fibers. The His bundle is located on the interventricular septum. This is the wall between the right ventricle and the left ventricle. And in general, the SA and AV node are usually supplied by branches of the right coronary artery. That concludes our module on cardiac anatomy.
నా పేరు భాను అశోక్, ఉదయ భాను.
Hello everybody and welcome to our module on cardiac physiology. On the screen is an echocardiogram of the left ventricle of a patient's heart. You can see there are QRS complexes rolling along the bottom of the screen, and each time there's a QRS complex, the walls of the left ventricle thicken and move towards the middle. When this happens, it shrinks the volume inside the left ventricle, rolling along the bottom of the screen, and each time there's a QRS complex, the walls of the left ventricle thicken and move towards the middle. When this happens, it shrinks the volume inside the left ventricle and pushes blood out into the aorta. You can see there are QRS complexes rolling along the bottom of the screen, and each time there's a QRS complex, the walls of the left ventricle thicken and move towards the middle. When this happens, it shrinks the volume inside the left ventricle and pushes blood out into the aorta. So in this module, we're going to talk about the changes in volume and the other physiological changes that occur as the heart goes through the cardiac cycle and pushes blood out of the left ventricle. As we saw in the moving image in the last slide, the volume in the left ventricle is changing during the cardiac cycle. However, there are two important volumes when it comes to understanding cardiac physiology. The first one is the end diastolic volume, or the EPV. This is the volume at the end. Because of the Starling mechanism, Hello everybody and welcome to our module on cardiac physiology. On the screen is an echocardiogram of the left ventricle of the patient's heart. You can see there are QRS complexes rolling along the bottom of the screen, and each time there's a QRS complex, the walls of the left ventricle thicken and move towards the middle. When this happens, it shrinks the volume inside the left ventricle and pushes blood out into the aorta. So in this module, we're going to talk about the changes in volume and the other physiological changes that occur as the heart goes through the cardiac cycle and moves blood out of the left ventricle. As we saw in the moving image in the last slide, the volume in the left ventricle is changing during the cardiac cycle. However, there are two important volumes when it comes to understanding cardiac physiology. The first one is the end diastolic volume, or the EDV. This is the volume at the end of diastole, that's how it gets its name. This is the point in the cardiac cycle where filling of the left ventricle has completed. This is the largest volume of blood the left ventricle will hold. This is also the point where contraction is about to begin. The other important volume is the first one is the end diastolic volume, or the EDV. This is the volume at the end of diastole, that's how it gets its name. This is the point in the cardiac cycle where filling of the left ventricle has completed. This is the largest volume of blood the left ventricle will hold. This is also the point where, that's how it gets its name. This is the point in the cardiac cycle where filling of the left ventricle has completed. This is the largest volume of blood the left ventricle will hold. This is also the point where contraction is about to begin. The other important volume is the end systolic volume, or the ESV. This is the volume at the end of systole, that's where it gets its name. This is the point in the cardiac cycle where emptying has been completed. This is the smallest volume that the left ventricle will hold. This is also the point in the cardiac cycle where relaxation is beginning. So now that we understand that, we can understand some other important terms as related to cardiac physiology. The first one is the stroke volume. This is the difference between the end diastolic volume and the end systolic volume. It's the amount of blood pushed out of the left ventricle with each heartbeat. It's the difference between the largest volume the left ventricle holds and the smallest volume it holds. Another important term is the ejection fraction, sometimes called the EF. This is the stroke volume divided by the end diastolic volume. In other words, it is the percentage of blood pushed out of the left ventricle with each heartbeat. The normal ejection fraction is about 55 to 60%. Our hearts don't normally eject 100% of the blood present in the left ventricle with each heartbeat. They only eject about 60% under normal circumstances. And then finally, which is called the EF, this is the stroke volume divided by the end diastolic volume. In other words, it is the percentage of blood pushed out of the left ventricle with each heartbeat. The normal ejection fraction is about 55 to 60%. Our hearts don't normally eject 100% of the blood present in the left ventricle with each heartbeat. They only eject about 60% under normal circumstances. And then finally, the cardiac output is the stroke volume times the heart rate. This is the volume of blood pushed out with each heartbeat times the number of heartbeats per minute. When you multiply these two terms together, you get a number called the cardiac output, which has units of volume per time. For example, liters per minute is a common way to report the cardiac output. Another important term is the venous return. This is the amount of blood returned to the left ventricle via the venous system. It should be equal to the cardiac output. The amount of blood that is returned to the heart from the body should be equal to the amount that goes out. And then another important term is the total peripheral resistance. This is the resistance to blood flow out of the left ventricle that comes from peripheral structures. For example, the organs of the body and the arteries of the body. Importantly, vasoconstriction of peripheral arterioles leads to a rise in the total peripheral resistance. When those vessels constrict, it's harder to push blood through them and there's greater resistance to flow. And when the peripheral arterioles vasodilate, this leads to a fall in total peripheral resistance. There are some blood pressure terms that are important for understanding cardiac physiology. You may know that we all have a systolic and a diastolic blood pressure, and a normal systolic blood pressure is about 120 millimeters of mercury, and then the diastolic blood pressure is about 80 millimeters of mercury. You should also know that the systolic pressure is largely determined by the stroke volume, and the diastolic blood pressure is largely determined by the total peripheral resistance. To understand this, let's imagine that we're tracking the blood pressure as the left ventricle begins to contract and push blood out into the arterial system. What we will see is that the blood pressure will rise, and the height of that rise will be determined by the stroke volume. In other words, when the left ventricle stops contracting and stops pushing blood into the arterial system, the blood pressure will peak, and that peak will be determined by how much blood is pushed out by the left ventricle. The blood pressure will then begin to fall steadily, and the depth to which it falls will be determined by the peripheral resistance. If peripheral vessels are very vasodilated, then the pressure will fall greatly, so that there'll be a very low diastolic blood pressure. On the other hand, if the peripheral vessels are relatively vasoconstricted, then it will only fall to a lesser degree, and vessel will have a higher diastolic blood pressure. So in this manner, the peak of the blood pressure, meaning the systolic blood pressure, is largely determined by the stroke volume, and the depth or the nadir of the blood pressure is largely determined by the total peripheral resistance. One other important blood pressure term is the pulse pressure.
Pranali, I am using a Prepladder. I mean, I don't have subscription right now. I just have books with me. Sohan, just go and visit my channel. You will understand. I'm not medical student anymore, dear. I completed my internship. I'm from 2017 batch. And what? DBMT and what's what? No, I am a neet-pg aspirant, Siddhi.
This is the difference between the systolic as the left ventricle begins. That's what it gets us here. This is the point in the cardiac cycle where emptying has been completed. This is the smallest volume that the left ventricle will hold. And the end diastolic volume and the systolic volume is the amount of blood that the left ventricle will chart as vessels constrict. Rise, and the height of that rise will be determined by the stroke volume. In other words, when the left ventricle stops contracting and stops pushing blood into the arterial system, the blood pressure will peak, and that peak will be determined by how much blood is pushed out by the left ventricle. The blood pressure will then begin to fall steadily, and the depth to which it falls will be determined by the peripheral resistance. If the left ventricle is determined by the stroke volume, and the diastolic blood pressure is largely determined by the total peripheral resistance. To understand this, let's imagine that we're tracking the blood pressure as the left ventricle begins to contract and push blood out into the arterial system. What we'll see is that the blood pressure will rise, and the height of that rise will be determined by the stroke volume. In other words, when the left ventricle stops contracting and stops pushing blood into the arterial system, the blood pressure will peak, and that peak will be determined by how much blood is pushed out by the left ventricle. The blood pressure will then begin to fall steadily, and the depth to which it falls will be determined by the peripheral resistance. If peripheral vessels are very vasodilated, then the pressure will fall greatly, so that there'll be a very low diastolic blood pressure. On the other hand, if the peripheral vessels are relatively vasoconstricted, then it will only fall to a lesser degree, and thus we will have a higher diastolic blood pressure. So in this manner, the peak of the blood pressure, meaning the systolic blood pressure, is largely determined by the stroke volume, and the depth or the nadir of the blood pressure is largely determined by the total peripheral resistance. One other important blood pressure term is the pulse pressure. This is the difference between the systolic and diastolic pressures. For example, for a patient with normal blood pressure of 120/80, the pulse pressure will be 40. And this is also proportional to the stroke volume. Remember what I told you before, the height of the blood pressure, meaning the maximum value or the systolic pressure, is determined by the stroke volume. This means that the difference between these two numbers, or the pulse pressure, is also determined by the stroke volume. Another important blood pressure term is the mean arterial pressure, or MAP. This is equal to the diastolic pressure plus 1/3 of the difference between the systolic and diastolic pressures, which you may recall is called the pulse pressure. The reason it's not halfway between the two pressures is because our blood pressure spends more of its time in the diastolic range. If you chart the blood pressure, you will find that it briefly goes up to the systolic peak and falls down to the diastolic range and stays down there for a much longer period of time before it climbs again. This means that in order to calculate the mean, you don't simply take the midway point between the bottom and the top. You take 1/3 of the way from the bottom, coming closer down to the bottom number because you spend more time down in this range here at the bottom. So for example, if our blood pressure spends more of its time in the diastolic range, if you chart the blood pressure, you will find that it briefly goes up to the systolic peak and falls down to the diastolic range and stays down there for a much longer period of time before it climbs again. This means that in order to calculate the mean, you don't simply take the midway point between the bottom and the top. You take 1/3 of the way from the bottom, coming closer down to the bottom number because you spend more time down in this range here at the bottom. So for example, if a person with normal blood pressure of 120 with a mean arterial pressure would be 80 plus 1/3 of the difference between those two, which is 40, and that would work out to 130. Of the cardiac physiology variables we've been discussing, one of the most important is the cardiac output. That's because the cardiac output
Yes, Vinayak, just now I have seen it. Siddhi, I am not from Delhi. I am using Prepladder and BTR, and I graduated from Vizag, from Andhra Pradesh. Guys, can you send messages now? Just please check. I couldn't.
must rise to meet the demands placed upon the heart by the body. And in many disease states, the disease is caused because of cardiac output.
Siddhi, I have answered them all. Just please check once. I am from Andhra Pradesh, Siddhi. I have completed my internship also. I am from 2017 batch. So, can you please delay your questions to the end because I am studying. Afterwards, I'll answer all your questions in the end of the session. Yeah, thank you.
Is insufficient. Also remember that the more cardiac output the heart produces, the more work it must do and the more oxygen that is required. The cardiac output is equal to the heart rate times the stroke volume, so when the heart rate goes up, there are more beats per minute, and this is more work the heart must do. In addition, when the stroke volume goes up, there's more volume per beat that the heart must pump, and that also means more work that the heart must do. These are very important principles of cardiac physiology for you to understand. So the four classic determinants of the cardiac output are the preload, the afterload, the contractility, and the heart rate. And we'll talk about these one at a time in the next few slides, but I just want to make a general point here that changes in these four factors affect the cardiac output, and that means that these four factors also affect how much work the heart has to perform. The preload is the amount of blood loaded into the provides, but I just want to make a general point here that changes in these four factors affect the cardiac output, and that means that these four factors also affect how much work the heart has to perform. The preload is the amount of blood loaded into the left ventricle prior to each contraction. That's how it gets its name, the preload. If you've watched the video on the Starling curve, you're aware that the more preload that goes into the left ventricle, the harder it will contract. And for that reason, when there's more preload, there's more cardiac output. In addition, when there's more preload, there's more work the heart must do. Preload is the amount of blood loaded into the left ventricle prior to each contraction. That's how it gets its name, the preload. If you watch the video on the Starling curve, you're aware that the more preload that goes into the left ventricle, the harder it will contract. And for that reason, when there's more preload, there's more cardiac output. In addition, when there's more preload, there's more work the heart must do, and more oxygen that is required. Because of the Starling mechanism, preload is sometimes referred to in textbooks as the amount of stretch on the fibers prior to contraction. Some books say length and some stretch, but all these are ways of referring to the preload and the fact that the Starling mechanism dictates that the more the left ventricle is loaded and the fibers are stretched, the more vigorously the left ventricle will contract. And if you find the concept of preload confusing, the way I've always explained it to students is to think of a room full of people, and the left ventricle's job is to push all those people out into the hallway through a small door. The preload is the amount of people put into the room. And you can imagine that if there are more people in the room, then there's more work that must be done in order to shove them all to the door into the hallway outside. So if preload is the amount of blood preloaded into the left ventricle to be pumped, how could you increase the preload in the left ventricle? Well, the easiest way is to add volume to the body. Patients who receive a blood transfusion or intravenous fluids will have increased preloads. These two interventions deliver more fluid to the venous system of the body, which goes to the left ventricle. This preloads the left ventricle with more fluid that must be pumped, and thus they increase the preload. This means that both of these things will raise the cardiac output. They will also raise the amount of work that the heart must perform. Another way that's not so obvious is to slow the heart rate. When you slow the heart rate, there's more time for filling of the left ventricle, thus it fills with more volume, and therefore there's more preload. And then a final way, which is very important physiologically, is to constrict the veins. The veins are like large storage basins for fluid inside the body. They contain a significant amount of fluid that can be pushed into the left ventricle if needed. So when the sympathetic nervous system is stimulated, alpha-1 receptors in the veins will react and constrict, and they will push lots of blood into the left ventricle. This is very important for the response to blood loss and venous constriction. It increases the amount of volume available to the heart and helps to maintain the cardiac output in the setting of blood loss. To decrease the preload, you do the opposite of the three mechanisms I just discussed. You can remove volume. Patients who are bleeding or dehydrated have decreased preload on the left ventricle. You can raise the heart rate. This allows less time for filling, the opposite mechanism we talked about before. In addition, you can pool blood in the veins, and this is the mechanism of action of drugs called nitrates, which are sometimes used in heart failure and angina. They dilate the veins, and they pool blood in the venous system. This pulls blood away from the heart. This lowers the preload. There's less work for the heart to perform, and for this reason, you can relieve angina. A couple of important terms regarding preload. Preload is often not called preload. usually referred to by one of the two terms I've shown on the screen here. The first one is the LVEDV, that's the left ventricular end diastolic volume. This is the volume I talked about at the beginning of this module. It's the volume of blood in the left ventricle when it's completed its filling phase. It's the largest volume of blood that the left ventricle will hold during the cardiac cycle. That is an indication of how much the left ventricle has been preloaded, and thus the LVEDV is usually used to represent the preload. Now in clinical practice, it's very hard to measure the LVEDV. However, it's much easier to measure the pressure at the end of diastole, the left ventricular end diastolic pressure. So instead of using the volume, we often use the pressure clinically because it's simply an easier number to obtain. This is the pressure in the left ventricle when filling is completed. This is also a measurement of the preload on the left ventricle. The afterload are the forces resisting flow out of the left ventricle. Remember that the heart must squeeze in order to raise the pressure in the left ventricle. It needs to raise the pressure enough to pop open the aortic valve so that blood can be pushed into the aorta. This is harder to do if, for example, the blood pressure is high. Blood pressure is one of the determinants of afterload. This is also harder to do if the aortic valve is stiff. Aortic stenosis is a classic because it's simply an easier number to obtain. This is the pressure in the left ventricle when filling is completed. This is also a measurement of the preload on the left ventricle. The afterload are the forces resisting flow out of the left ventricle. Remember that the heart must squeeze in order to raise the pressure in the left ventricle. It needs to raise the pressure enough to pop open the aortic valve so that blood can be pushed into the aorta. This is harder to do if, for example, the blood pressure is high. Blood pressure is one of the determinants of afterload. This is also harder to do if the aortic valve is stiff. Aortic stenosis is a classic condition where the afterload increases. There are also some rare forms of high afterload, such as when things are in the way of blood moving out of the left ventricle. This can occur in hypertrophic cardiomyopathy. It can also occur in rare conditions like when patients have a subaortic membrane obstructing the outflow of blood. But all of these things raise the amount of work that the heart must do in order to move blood out of the left ventricle. And just like with preload, an easy analogy to understand afterload is to think of a bunch of people in a room, and it's the left ventricle's job to push them through a doorway into the hallway outside. The afterload is high if there are already a lot of people in the hallway outside. It's absolutely harder to move those people out of the room and into the hallway. And that's what happens when your blood pressure is high. There's already a lot of high pressure and molecules outside of the heart, therefore it's harder to move blood out of the way. It's also harder to move those people out of the room and into the hallway if the door is stiff and won't open, and that's what happens in aortic stenosis. So these are ways you can think of the concept of afterload. So just like we did with preload, let's talk about ways we could increase or decrease the afterload. So one of the ways to increase the afterload is to raise the mean blood pressure. Mean blood pressure is one major determinant of the afterload of the left ventricle. Another way to increase the afterload is to obstruct the outflow of the left ventricle in some manner. This is what happens when patients have aortic stenosis or hypertrophic cardiomyopathy. To decrease the afterload, we could do the opposite of the two things I mentioned on the last slide. We could lower the mean blood pressure, we could treat the aortic valve disease or the hypertrophic cardiomyopathy. And the principle here is the more afterload means more work the heart must do, and therefore more oxygen that is required. Now let's talk about the third determinant of cardiac output, that is the contractility. This is how hard the heart muscle squeezes. And the ejection fraction is one potential measurement of contractility. When the ejection fraction goes up, it means that the left ventricle is contracting more vigorously, pushing more blood out of the left ventricle with each heartbeat. And the major regulator of contractility is the sympathetic nervous system. This is the major regulator under physiologic conditions of both contractility and also heart rate, which we'll talk about in a minute. The main physiologic mechanism by which the things I mentioned on the last slide. We could lower the mean blood pressure, we could treat the aortic valve disease, pushing more blood out of the left ventricle with each heartbeat. And the major regulator of contractility is the sympathetic nervous system. This is the major regulator under physiologic conditions of both contractility and also heart rate, which we'll talk about in a minute. The main physiologic mechanism by which contractility is increased is via sympathetic nervous system activity. There are two mechanisms by which the sympathetic nervous system can increase contractility. First of all, the sympathetic nervous system directly innervates the heart. In addition, the sympathetic nervous system can stimulate the release of catecholamines from the adrenal gland. Those can circulate and reach the heart. Those include substances like epinephrine and norepinephrine. When either of these mechanisms activates the heart, there's increased calcium release from the sarcoplasmic reticulum, and this will increase the contractility. So some classic triggers are stress, also exercise, which we'll talk about later, anything that increases sympathetic nervous system activity. A non-physiologic way by which contractility can be increased is via the use of sympathomimetic drugs. These are drugs like dopamine, dopamine, epinephrine, and norepinephrine. They all stimulate sympathetic nervous system receptors in the heart, and they exert the same effects that the sympathetic nervous system normally does under physiologic conditions. And then finally, the drug digoxin, which I'll talk about in some of the other cardiology modules, inhibits the sodium-potassium ATPase pump. This leads to an increased calcium level inside of myocytes. This is another non-physiologic way to increase contractility. The main way that contractility is to increase calcium level inside of myocytes, this is another non-physiologic way to increase contractility. The main way that contractility is decreased is by dialing back the sympathetic nervous system. This can occur naturally when patients enter states where there's less sympathetic activity. It can also occur via the use of drugs. So the main mechanism of sympathetic nervous system blocking drugs like beta blockers on the heart is to decrease contractility and also heart rate, which we'll talk about in a minute. Some calcium channel blockers, especially verapamil and diltiazem, also affect contractility. They lead to less calcium being pulled into myocytes, and therefore there's less calcium available for muscle contraction and decreased contractility. And then finally, heart failure, especially systolic heart failure, is a disease of myocytes that results in decreased contractility. That's the defining characteristic of the disease. Our fourth determinant of cardiac output is sympathetic nervous system receptors in the heart, and they exert the same effect. Effects that the sympathetic nervous system normally does under physiologic conditions. And then finally, the drug digoxin, which is of sympathetic nervous system blocking drugs like beta blockers on the heart, is to decrease contractility and also heart rate, which we'll talk about in a minute. Some calcium channel blockers, especially verapamil and diltiazem, also affect contractility. They lead to less calcium being pulled into myocytes, and therefore there's less calcium available for muscle contraction and decreased contractility. And then finally, heart failure, especially systolic heart failure, is a disease of myocytes that results in decreased contractility. That's the defining characteristic of the disease. Our fourth determinant of cardiac output and the work of the heart is the heart rate. When the heart rate goes up, this increases the cardiac output under physiologic conditions. And the main regulators of heart rate, the factors that cause it to increase or decrease, are the same ones that affect contractility. In general, heart rate and contractility go together. They are both mainly regulated by the sympathetic nervous system, and they are both also affected by some pathomimetic drugs and blocked by drugs like beta blockers. There is a confusing concept about heart rate. And the main regulators of heart rate, the factors that cause it to increase or decrease, are the same ones that affect contractility. In general, heart rate and contractility go together. They are both mainly regulated by the sympathetic nervous system, and they are both also affected by some pathomimetic drugs and blocked by drugs like beta blockers. There is a confusing concept under physiologic conditions. And the main regulators of heart rate, the factors that cause it to increase or decrease, are the same ones that affect contractility. In general, heart rate and contractility go together. They are both mainly regulated by the sympathetic nervous system, and they are both also affected by some pathomimetic drugs and blocked by drugs like beta blockers. There is a confusing concept about heart rate and stroke volume that's shown in many cardiac physiology textbooks, and I'll explain this to you in the next few slides in a way that hopefully makes sense. So in laboratory settings, when you insert pacemakers into the hearts of animals like dogs and you artificially increase the heart rate, you see a fall in stroke volume. This is because there's less time for filling of the left ventricle. So the relationship between heart rate and stroke volume experimentally is like what I've shown on the screen. Now this is very counterintuitive. Most of us think of our output of our heart going up when our heart rate rises, and this slide indicates the opposite. But keep in mind, this is under artificial settings in the laboratory when you're increasing the heart rate without also raising the contractility. Even in artificial settings like the laboratory where you're pacing the heart of a dog, an increase in heart rate over physiologic ranges of heart rates still leads to a rise in cardiac output. That's because even though the stroke volume falls when the heart rate goes up, like I showed you on the last slide, the heart rate rises to a greater degree. And remember, cardiac output is equal to the product of stroke volume times heart rate. Thus, if you have a small drop in stroke volume but a greater rise in heart rate, the net effect would be to increase cardiac output. So thus, even in the laboratory, when you're studying animals and you're pacing their heart, as you increase the heart rate, you still see a rise in cardiac output, even though the stroke volume is going down as you raise the heart rate. That's a confusing concept to make sure you understand that. All of those relationships I just showed you, however, are artificial because under physiologic circumstances, the sympathetic nervous system controls heart rate and contractility, And it never raises the heart rate alone without also raising the contractility. What this means is when the sympathetic nervous system raises the heart rate, the stroke volume goes up. Even though there's less time for filling, there's more contractility, such are artificial because under physiologic circumstances, the sympathetic nervous system controls heart rate and contractility, and it never raises the heart rate alone without also raising the contractility. What this means is when the sympathetic nervous system raises the heart rate, the stroke volume goes up. Even though there's less time for filling, there's more contractility, such that overall there is a rise in the stroke volume under physiologic conditions when the sympathetic nervous system raises the heart rate. The one clinical situation where a rise in heart rate can lead to a fall in cardiac output is under pathologic conditions in the setting of some cardiac arrhythmias. There are some cardiac arrhythmias where the heart rate can get very, very high, sometimes as high as 300 beats per minute. In this setting, there isn't enough time for the left ventricle to fill, and thus the stroke volume falls and the cardiac output falls. In other words, at these very high heart rates, even though the heart rate is increased, the stroke volume has dropped dramatically. Thus, the product of stroke volume times heart rate begins to fall. That means the cardiac output gets low. What this means is that some patients with cardiac arrhythmias can develop hypotension and shock, and this usually happens when the arrhythmia results in a very rapid heart rate. What this means is the true relationship between cardiac output and heart rate is like what I've shown on the screen here. Under the physiologic range of heart rates, when the sympathetic nervous system drives an increase in the heart rate, there is an increase in cardiac output. This is because the sympathetic nervous system is increasing contractility in addition to heart rate, and thus the cardiac output is going up. However, if the heart rate gets very, very high, for example, in the setting of arrhythmia, you can reach a point where the cardiac output begins to fall, and that's because of the dramatic drop in stroke volume seen when the heart rate gets very, very high. So to summarize, the work of the heart is determined by four key components. The first is the preload, which we often estimate by the left ventricular end-diastolic volume or pressure. The second is the afterload, which is often estimated by the mean arterial blood pressure. The third variable is the contractility, which is often estimated by the ejection fraction. And the fourth is the heart rate. And this will be important when we talk about disease states because hearts that are starved for oxygen need to have these factors modified so that there's reduced oxygen demand. In addition, hearts that are generating a low cardiac output need to have these factors modified so that they increase the work of the heart and increase the cardiac output. And that concludes our module on cardiac physiology.
Thank you, Sudhi. Thank you, Medicine 360. Happy Dasra too. I'm studying cardiac physiology right now. Dheeraj, I mean, other timing is not so suitable for me. So, it helps you wake up early in the morning, right? You have to habituate waking up early in the morning if it's okay for you. Mhm. Then I think you should study for yourself. I could do anything. Night time, my mom usually don't accept me to do live sessions. I have been continuously poked for you know studying without any phone or so. So I must not use any phone at that time. There is nothing. I'll just close the live session for now. It depends, Dheeraj. Usually I study for at least 6 to 7 hours a day. There is a maximum I can put right now. But right now, because of festival vibes and all, I'm studying just 3 to 4 hours. It's been all these 9 days I have been studying 3 to 5 hours. That's it. Krishna, is it so difficult to wake up 5? I mean, if you sleep at 10 o'clock, you will be able to get up early in the morning at 5 o'clock. Those people who are habituated to waking up at 5 o'clock will suffer now if I change the timing. Uh, it's some it's from pop something like prop store or something. Some website in Google. You can just search from it. Prop store or something. I don't remember Kritika. Just I don't remember. Uh, I think early in the November or December, I guess. But it will be delayed this year, I guess. I'm not Coach Krishna. I'm just another friend, like virtual friend, so that we all can study together. Rajesh, I feel there is nothing. There is no terms like consistency. It is just you being able to sit at the study table and just study. Don't if you keep something like consistency, I have to stay consistent. I will Yesterday I didn't study, today I have to study. I mean, if you have constant thoughts like that, you will uh, you know you will suffer. I mean, I have done that. That is why I start thinking about that. What I am doing is I have to sit and study. Whatever it is, I have to study that day. I have to learn something new. That is what I am doing right now. I mean, in last neet-pg I thought I have some topics left out. Not some, there are so many topics left out. I thought if I didn't get a seat, I have to concentrate on this next time, because I have no idea about them. So I'm doing that right now. It is difficult for me also, Rajesh, to get up to study at 5 o'clock. It is difficult not only for you, it for also me. um, I don't know how I'm maintaining, but no, one second. So sleep at 10 o'clock, you will be able to wake up at 5 o'clock, Rajesh. That is what I am doing right now. Sometimes it becomes 10:30, but I'm pushing my body to get up and sit at the study table. First 5 minutes I have that urge to sleep, want to close the books, but after 5 minutes, after some time, I'm getting habituated to it. Yeah, I'm Dheeraj. I'm solving custom modules, 50 MCQs per day, and if possible, subject wise, Q bank from Arrow. Krishna, there is no need to, have FOMO like that, because I use multiple resources thinking that it will work for me. I mean, it depends on person to person. There are so many people on YouTube. Not everyone's strategy is same for them to get that rank. So it I don't remember my ID, but you can just mail me in the Gmail, Rajesh. I can just give you QR code. So, Krishna, I think it's a wrong perception that if BTR is done, and I am, I am backward or something like that. You can't just think like that. Okay. Uh, Just go through my description of YouTube channel. There it is. You can directly go through it. If not, then I'll tell you. One second. Prop website not visible. I have purchased it from there. You can do one thing. You can just um, type keywords like study planner, like that. You will get multiple, even better than my planner. Yeah, Rajesh. Yeah, I think if that's it. No, Rajesh. No, Krishna. I'm not writing any set. I'm not writing any set. No, I'm not adapting it. I'm not confident enough. Um, at least I want to complete full-fledgedly. If I get some good rank in neet-pg, I would have attempted it, but no, I'm not attempting it right now. Being OC candidate, we need to get at least 100 or so for getting a desired rank. So I'm not underestimating myself, but I need some time to do it. Okay, attempt it, Krishna. It is up to you whether you attempt it or not. It's not like you won't get. It's just that I don't want to do it. And also, I don't want to leave my hometown is another FOMO that I have. We are all at same pace, Dheeraj and Krishna. We are still at that ranks of evening live session. I just many people are asking, but I'm thinking whether it is possible or not. I'll try to do it, but I can't say for sure whether I will do it or not, because see guys, then have to see whether it is possible or not. I'll try to do for some days. If it is going good, then I'll do it. I mean, there are so many channels doing lives in the evening. I think you can follow them if you want. And there is so much to study. No, guys, everyone are the same. Just that I am being visible, in the screen. नीट पीजी की नहीं आई. No, there are people who are you know present for neet pg. I have seen people doing lives. Any question, I mean subject related questions you wanna ask? We'll close the session right now. I'll ask you something later. This prepared a rapid revision notes of physiology I am studying right now. Cardiovascular system, Dheeraj. Siley Lewis uh, one second, I need some time. Is it present on platelets? Is it present on platelets, Krishna? Okay, okay, Krishna. I don't know what to ask from physiology, how questions are framed. Uh, um, Krishna, see, this is a personal opinion of mine. For some subjects, I am doing main notes. Like this time, I am adding mini Harrisons to my preparation of medicine because I feel somewhere I am lacking in medicine. So I am adding. There is some book called Mini Harrisons. I'll just show you. Wait, by Mukesh Bhatia. I love this book. I don't know why, because I never studied main notes or main books for studying. This is the book Mini Harrisons of Mukesh Bhatia, which is Medicine Simplified. Excellent book. I love the book like anything. I mean, I just love reading the book. It is very nice, very easy and understandable way for. No, I don't use Bhatia for that particular subject. I mean, for medicine, I am using it. I have started using it recently. Some senior have gave me all the books of Bhatia, but out of all the books, I found Medicine Simplified, which is very useful. So, for anatomy, Prepladder Rapid Revision is only giving so much of information, so I'm not going to do any other book. Between anatomy is very scary subject for me, so I'm doing only anatomy Prepladder Rapid Revision. But for medicine, I am doing it from main, Mini Harrison book, which is of so much content. But I love reading the book. You can answer any question if you read that book. Um, yeah, I think I am doing it for medicine. Um, I am also doing it for pharmacology, pathology. Pathology, I am not reading Robbins per se, but I am doing from Preeti Sharma ma'am's notes. Yeah, you can do that. I will, reply as soon as I see it. I am hoping at least, I am thinking of completing along with BTR schedule given by Zainab ma'am. I mean, after November, NSET madam will give a new schedule, I guess. So I will start doing it until the first read of ma'am's schedule gets completed. I should complete my first read. That's what I thought. I'm using Yule Pumta. If you have seen my videos, you would have known that I have been using Yule Pumta, guys. Yeah, I'm using Prepladder, BTR, and Bhatia's Medicine Simplified book for medicine. That is what I'm using right now. Prepladder में I am using both main and rapid revision depending on the subject which I have studied. Like if I have studied in internship like short subject I have completed main notes, so for that I'm doing that. For anatomy and some scary subjects I'm doing rapid revision. For some subjects which I feel BTR is not giving complete information, for that subjects I'm going for that. It completely depends on how you are doing it. It is not, you have to use trial and error methods here, which is working for you, which is not. Analyze yourself, keep time for yourself. Yeah, Kritika, that is why I have included some new things to my preparation. Yes, that is why I have done already one to two to three revisions last time of BTR and pep ladder, main notes of some subjects. So now I am incorporating information to it. We'll see, Dheeraj. No controversies here. We have to wait and see what happens next. I think we have to close the session. I have to go to duty. Even on the festival day, we have duty. So I think we have to close the session here. Is there anything anyone wants to ask, or shall I close the session? Okay. Okay, Dheeraj. Same time, Krishna. 5 to 6:30 is the time. Happy Dasra to Dheeraj. Don't get tense too much. Just enjoy the day of festival. Happy Dasra, Kritika. I think that's it. Bye, guys. Bye, Krishna.